Good morning, Namaste. I'm Dr. Manish. I welcome you all in the HICS 8 Symposium. At the outset, I would like to express my thanks and gratitude to my dear friend, Dr. Srinivasan Samvedam and Dr. Ghanshyam for giving me this opportunity to be here with you and sharing my insights related to this topic, which is cardiac power output. In the next 15 minutes, I am going to share this topic, which otherwise has been rarely spoken into any intensive care meeting. However, if you see, this topic has a huge relevance when it comes to the contemporary cardiac intensive care practices. So, my dear friend, here we go. So, cardiac power output, uh, this is not a new tool. Actually, the first description of this tool has been given as early as in 1990 by Ten et al., where he has studied almost 28 patients and their response to dopamine therapy. The reason I'm sharing with you that although this tool is not so new, however, his role has been now well elucidated in the contemporary cardiac intensive care practices. Through this tool, we are trying an honest attempt to make the hemodynamic better. Not only we are going to make it better, we are also through these mechanisms, we are going to translate into the patient outcome as well. The first and foremost, the question which we should ask that why we need this kind of a new tool. The second question which we are going to answer that what is CPO, cardiac power output. The third thing which we are going to learn in this presentation is that CPO, although is very important in the present contemporary cardiac intensive care, but this has to be seen in addition to the existing metrics which are available through the invasive hemodynamic parameters, through the invasive hemodynamic monitoring. Obviously, we are going to study the supporting evidence and the clinical relevance of this tool and many other associated tools in the contemporary management of cardiogenic shock, especially in the setting where the patient is requiring MCS and without MCS as well. Now, why we need this, or why we needed actually this kind of an assessment tool. And now, if you can see in the slide, almost in a typical cardiac intensive care unit, which has been taken up from the circulation, if you can see that almost 66% of the cases in cardiac ICU, they are typically of cardiogenic shock, which means 2/3 of the patients we will have cardiogenic shock in a CCU. And out of this 66%, almost 50% of the cases, they will be having ischemia in origin. Why I'm talking about ischemia is so that the ischemia is something which you can revert, you can actually revascularize, you can catheterize and do some intervention to make them salvage. The cardiogenic shock has a huge mortality burden. 50% of the cases, they are going to die in the first 30 days, the short-term mortality. If you see, despite of having so much of advances, as we have gone through the shock trial, the IBP shock 2, where IBP has been promulgated, and the IMPRESS, where the role of Impella has been elucidated in a patient with severe cardiogenic shock, still they continues to have a high mortality of 50%. This 50% is not only in short term, but also even if you follow them up for a year, you find that they don't survive, despite of the use of mechanical circulatory assistance. Obviously, to fill this gap, we needed some better methods of not only the assessment, but also to intervene. The role of CPO has been given in 1990 by TAN. However, the biggest impact has been through this paper, which was a shock trial registry, which was published in 2004 in ACC. And what they came with the conclusion that out of all the parameters which they had, the CPO has the strongest hemodynamic correlate of outcome in cardiogenic shock. However, it needed the right height catheterization in order to pick up and measure this data. Through this paper, they have shown that clearly the CPO emerged as the winner uh, in all the possible analysis. This was the one which has the strongest impact, the measurable strongest impact on the survival of the patient. You can see in this diagram, on the x-axis we have a cardiac power output, on the y-axis we have cardiac mortality, in hospital mortality. When the CPO is less than 1 watt, you can see how exponentially the mortality in hospital has got risen. So obviously we needed better parameters to bridge this gap. We needed something to be very specific, sensitive. We wanted to assess, like the fluid responsiveness, we know that the patients in a cardiogenic shock, they are sick, they are going to die. Obviously, we need better way of making an assessment for them. We have studied a lot when it comes to fluid responsiveness. We wanted something like fluid responsiveness. Can we have a cardiac responsiveness through which we can actually elucidate and understand whether my patient needs fluid or inotrope or vasopressor or mechanical circulatory device? And even if we are using them, how the patient they are responding to that intervention is also something is, is of extraordinary importance. We want to make everything well cited through the evidence, not just pragmatic driven. Where we are right now. Right now, we have the direct metrics which are available. Obviously, they are based on the PAC, the pulmonary artery catheters, like CVP, pulmonary artery pressures, pulmonary capillary wedge pressures, mixed venous oxygen saturation. But what we are interested in this presentation are the indirect parameters like CPO, the PAPI, which is known as pulmonary artery pulsatility index, the CVP by PCWP ratio, SVR, and PVR. We are not going to discuss all the parameters. This 15 minutes, I can only do the justice onto the CPO and the PAC-based data, but they are the most important cornerstone of your assessment on which you're going to guide your intervention. So what is CPO? CPO is a pumping ability of the pump. The heart is nothing less than the hydraulic pump. The pump has to function. Not only it's a machine which is going to convert the mechanical energy into hydrostatic energy. This hydrostatic energy is going to be reflected in terms of the cardiovascular flow and the pressure. So the cardiovascular flow is basically the cardiac output, and the pressure is basically the mean arterial pressure. We have measured, I'm going to tell you how, the resting CPO, which means when I'm at rest, 1 watt is something which we all have. When we are under the stress or we are exercising, stress could be physiological or pathological. Under the stress, a normal nave heart can increase the cardiac power output by up to 6 watt, which means from 1 to 6, almost 5 watts, they are extra recruitable, which are available for us. However, in the disease like CHF, AHF, and cardiogenic shock, we have seen that this recruitable reserves steeply goes down. So how to measure? The CPO is basically nothing. It's a very simple concept. You just have to multiply the MAP and the cardiac output divided by 451, which is a constant. The point which you need to remember is that if your patient is having a high right atrial pressure or the CVP, then you have to see the second equation into the consideration, MAP minus RAP into CO by 451. For the initial equation, we believe that the CVP is not significantly high, which is around 0 to 3 or 0 to 4 maximum. So it hardly make an impact. But in case if your patient is having right ventricular failure, you can expect the CPO has to be adjusted for the RAP. The CPO in most of the studies has been found when it is less than 0.53, especially the most important paper, the shock trial registry, which I have just spoken, it reflects with the in-hospital mortality. This was the paper which I was talking about. In the first slide, this was the benchmark paper which has given you the basics foundation pertaining to cardiac power output. This was published in 1990 in the British Medical Journal. Now, obviously, to obtain the cardiac power output, your patient need the Swan catheter. So to obtain CPO, you have to swan the heart. Now, the point which I wanted to impress upon that when you're going to swan the heart, you also need to know and you also need to profile the various pressures like right atrium, right ventricle, PA, PCWP, the pulmonary artery systolic and diastolic pressure. And I'm going to let you know in the next few slides that how, when you know all this pressure, including RA, RV, PASP and PADP, PCWP, and cardiac output. We call it as a complete hemodynamic profiling. The point which I wanted to impress upon at this side is CPO is an important adjustment tool, but it has to be seen as a part of complete conglomeration of the hemodynamic profiling. And in order to obtain the reliable CPO, there has to be an invasive right heart catheter, which is nothing less than the Swan catheter. The point here is that because the Swan-Ganz catheter has gone down, the reliability through which you are going to obtain the CPO has also suffered. Nevertheless, you can obtain CPO with the help of non-invasive cardiac output monitoring, but it's not going to be very reliable. All the dedicated cardiac centers, they replicate this information of CPO on the basis of your invasive catheterization. So CPO is not all enough. We need complete hemodynamic profiling. Need of the hour, as I discussed, is the cardiac responsiveness, which I've spoken, complete hemodynamic profiling, and thereafter the appropriate intervention on the basis of your profiling, whether my patient has a problem with the SVR, the PVR, or the mixed venous oxygen saturation, the PSP pressures. Then on the basis of this, I have to take an intervention apart from the neometrics like CPO, the PAPI, and the ratio between the CVP by PCWP. This has been well elucidated in this paper, which has been published in 2020. Dr. Rishad Guerin has done the maximum work. I would like to acknowledge the work which Dr. Guerin and Dr. Saxena has done. They are the maximum impactful work which has been done on this subject. And what they came with the conclusion, when you have a complete hemodynamic profiling, then you have the least hospital mortality. And it is very important to initiate this hemodynamic profiling on the basis of the PAC-derived parameters, even before the initiation of MCS. There's another paper which has got published, which is values on the hemodynamic monitoring in cardiogenic shock in a mechanical circulatory assessments. Everybody has a studied CPO without MCS. But Dr. Saxena et al., including Dr. Guerin, they have also studied the relevance of this parameter, the CPO, apart from the complete hemodynamic profiling, which I have spoken, which include your CVP, the right, which is your right atrial pressure, the right ventricular pressure, the pulmonary artery systolic and diastolic pressure, the cardiac index, the cardiac output, the and your PCWP. That actually is a complete set of variables which you are supposed to study and take the decision on the basis of this. He has given this 5 phenotypes, the clinical phenotypes, extremely important. They are nothing although less than the representation of the Forrester classification, the 4 quadrants. What they have added is the pre-shock normotensive hypoperfusion or the pre-shock hypotensive normoperfusion, which are the 2 important variants which you normally see even before there is a classical cardiogenic shock. So these are important things. I encourage each one of you to go through with this paper. This is going to help you. And my dear friend, just if you can look, they have given you that on the basis of PAPI, your CVP by PCWP, and the CPO, how can you define these clinical phenotypes? The fate of pulmonary artery catheter has declined a lot in the last 30 years. They have said in this paper almost from 30 to 45%, what it used to be 40 years back, it has gone down to 4.5%. However, it has seriously encouraged us to reflect that when you're talking about all these parameters like CPO, you need to have a reliable method of an assessment as well. So it has clearly said that there is a significant place of this PAC catheter, especially in the management of most complex shock. However, the careful selection of your patients, the correct implantation technique so that you can avoid those kind of gross mechanical errors, the meticulous analysis of the data, which has actually suffered. We know how to SWAN, many of us, but the interpretation is really crippled among the the healthcare colleagues, and thereby the intervention, which is dependent upon your interpretation, also suffer. So these things, they must remain to be a part of your teaching, your understanding, and your practice, because if it is clearly understood, it has a strong impact to change an outcome. I want you to focus on this red line, which clearly has said that the higher the number of vasopressors or the vasoactive drugs, less of it will be survivable. So if your patient is on 3 vasoactive drugs, you can expect the mortality of almost 60 to 65%. If your patient is on 4 vasopressors or 4 vasoactive drugs, you can expect that the 80% or 84% they are going to die. That actually reflects that in patient, when you find that the CPO is less than 0.6, or even if it is less than 1, and there's no point of just bombarding the heart with the pharmacotherapy, because somewhere this pharmacotherapy is counterproductive in them. So I'm going to study this case in the next 2-3 minutes. We have a 67-year-old man who's a diabetic, hypertensive, hypercholesteremic, chronic smoker. Post-cabbage, he came with a chest pain, TROP2 positive. In short, he was having ACS. His BP was initially normal. Yes, now we have to go into the classification, but it is definitely less from 140/70, what used to be baseline. But his perfusions are not bad. So he was due for the cardiac catheterization. Later in the day, he got worsened, tachycardic, BP further went down. He went into a poor urine output, poor perfusion markers. The shock team got activated. The PA data, which has been now on your screen, is definitely sensitive cardiogenic shock. But if you see the CPO is 0.5, which means he is very poorly placed in terms of his prognosis. And these kind of cases, they do worse. So they do need urgent MCS. The PAPI, which is more than 1.5, which is although beyond the scope of this case discussion, but it helps you in understanding whether RV is contributing to the cardiogenic shock or not. So once you have this complete hemodynamic profiling, it's easy for us to understand that the patient had a complete cardiogenic shock with predominantly LV failure phenotype, because the CVP, the CVP, PCWP, they were perfectly okay. Definitely the SVR was on the high side, so they need more of some inodilator. Because the CP was poor, they indicate poor prognosis, and it warrants early MCS or mechanical circulatory device. And in this kind of cases, LVADs, which improves the left ventricle unloading, they are better placed. So what are the strategies which work in this case? Now, this is something which is going to be my last slide. The strategies which has worked in a patient who are having a shock, more specifically the cardiogenic shock, early diagnosis. So we need both clinical and hemodynamic criteria. Surprisingly, European Society of Cardiology in 2016 has taken off the hemodynamic criteria to qualify the patient as cardiogenic shock. And it's coming up again that we should include this as a part of your routine assessment. Not only just knowing the clinical early diagnosis, we also have to do early hemodynamic profiling. Why we need to do early hemodynamic profiling? Hemodynamic profiling is going to help you in understanding the cardiac responsiveness, that what should be given to my patient, and whether it's an inotrope or a vasoactive vasopressor or a vasodilator or the fluid, depending upon the invasive catheterization, invasive data which you're going to obtain from the right heart catheter. There has to be a structured, dedicated shock team. The shock team where the role of intensivists now cannot be undermined, right? And this has been a game changer when it comes to the patients who are having a cardiogenic shock. This is taken from all the evidence-based practices and the early use of MCS. When your patient is more in terms of your vasoactive therapy, especially when it is crossing more than 1, and your CPO is less than 1 cardiac proper output, it's time for you to ring the bells and think whether my patient qualifies for early placement of mechanical circulatory device, rather than when the patient is in an impending doom or the extremis stage. Obviously, now you are going to guide your stratification and your prognosis. So my dear friends, I would like to end my presentation with that the success of intensive care is not therefore to be measured only by the statistics of survival, as if each death is a medical failure. Rather, it has to be measured by the quality of life preserved or restored, and by the quality of dying of those in whose interest it is to die, and by the quality of human relationships and the interaction which are involved. So thank you, my dear friends. Thank you for making the difference in the field of intensive care. And thank you, everyone, for your patience listening. Bye-bye.